I will be quite brief. I will try to be as brief as possible. I know everybody is late. So, in general, I'll be talking about cervical disc replacement, and I will try to make it as simple as possible, especially for the juniors here, because a lot of orthopedic surgeons who don't have background don't do a lot of cervical spine surgery. So, this will work as a sort of a guide for cervical disc replacement as well as normal discectomy. So I will be covering it in these basic headings. We'll talk about cervical displacement indications and contraindications. And we'll talk about basic preparation, then exposure, and then of course decompression and choice of implant and placement of implant. So starting with the first part. So indication for cervical displacement is either single or two levels. So you cannot go for more than two levels, at least at this point in time it's not been approved. In case the patient has got a radiculopathy or even myelopathy is now indication for cervical displacement. Earlier it used to be a contraindication. Also the patient has to have not just radiculopathy but also a possible cause for that. For example, a herniated disc prolapse or osteophytes, or one can see that there's a visible loss of disc height which can explain the foraminal stenosis. And of course, it should have failed conservative treatment. And in terms of contraindication, extremely important because we do tend to be enthusiastic about placing cervical discs by a CDR, especially if you've done a few cases of normal ACDF and anterior cervical plating. So it's extremely important not to do this surgery for patients who only got neck pain. There are other contraindications as well, but segmental instability is also one of the major contraindications. Similarly, if the disc height is really less, and that means it's practically degenerated, we should not consider cervical displacement for such patients. And also if there's a facet degeneration which is severe. In those cases also, if you can't see the joint line, there's no point going for a cervical disc replacement in these cases. Another contraindication is the fact that you should be able to see the involved disc space on a lateral X-ray. So, of course, there will be general anesthesia, and we have to make sure we have to avoid extension of neck compared to which you normally do for cervical disc fusion, because in this case you want it to mimic as much as a neutral lateral X-ray as possible, so that the disc is always in a position to move. The table has to be radiolucent. Here we can't compromise because you need to see AP views all the time, especially for mimicking the midline and for determining the midline. So apart from that, this is pretty standard information. There's not much difference in choosing right or left. In general, most surgeons will follow tradition. We've seen neurosurgeons do from right and orthopedic surgeons do from left. But in general, if there is a patient who's got a rectal nerve palsy, in those cases, you should do it from the same side. And if the surgery has already been done before, then try to avoid that side. Try to go to the opposite side. There are doctors who are doing it by loop, but in general, it's better to go for microscope because in general, it gives you a better, you can say blight imaging as well as helps your assistant to assist you placing the retractor and things like that. Incision is usually transverse for a cervical displacement because we're not going for more than one or two levels. Also, the landmarks can be used in a standard manner or use fluoro. Incision is, of course, just medial to the sternocleidomastoid. Initial dissection is at level of subcutaneous fat and platysma. This is just undermining of platysma is important in this case so that you don't place a lot of retraction on the skin. I will discuss the integrities of this approach. We are going to basically use this approach and we'll discuss the various fascias and how to access them. So this is a superficial fascia which is obviously investing only the sternocleidomastoid. You have to cut medial to it and should be a sharp dissection. As you go down, you reach the middle layer, you will be seeing the omohyoid and strap muscles. You have to go between them. The dissection has to be blunt. You can't be sharp here in general because you can go sometimes through the muscle fibers. Then the other part of the middle layer is encasing the carotid complex. This is very, very important. Here it's better to use a finger dissection so that you're able to palpate the carotid artery and keep it lateral. And as you go between the tracheoesophageal complex and the carotid complex, you will reach the deep layer. So at the level of the deep layer, you have longer scoli. In that case, you have to go for a sort of a sharp dissection. So talking about this is just a few images to show you the view, the axis again. I'll skip the video. So for longest coli, which is we find a lot of beginners face trouble is that they're not able to find it way to dissect and retract. So start with a bipolar, and then go for a monopolar, periosteum elevator, then again bipolar, elevate, retract. Make sure you avoid sympathetic plexus. That is on the longest coli, slightly lateral. Because if you injure that, you are likely to land into Horner syndrome. I've not seen it, but I've heard speakers talk about it quite often. So retractor placement is standard. This is your okay. So very very important. The initial pin placement. It has to be bang in the center. So see if you can take the help of fluoro to find the midpoint, or take the help of uncinate process. So uncinate process will curve cranially on either side. So just look at their origin and then mark the midline. And of course, the pin have to be parallel to one another. Extremely important. And then we're talking about discectomy, which is a standard process. You have to. So there are a lot of questions people ask, say, whether in disc replacement surgery you should be doing uncinatomy or not. If it is required, you have to do it. So loss of uncinate process is not a contraindication for disc replacement. Similarly, osteophytes have to be removed completely. Thirdly, PLL has to be open. So there is no such thing that for a disc replacement, artificial disc to work, you have to leave the PLL intact. So this is an example of a patient with a lot of osteophytes. So you remove it, go all the way. There's no harm in that. Then we're talking about the end plate preparation. So this is also another question that often comes up, is whether we can use drill in patients who are requiring this replacement. Yes, drill can be used as long as after the complete decompression you are lavaging that area and getting rid of all the bone fragments. So end plate preparation has to be very meticulous. You can't overdo it. And similarly, you have to make sure that the deepest part of the vertebral body is completely taken care of, because often we find a lot of people will put artificial cervical disc and that disc will be coming out anteriorly because they were not able to push it deep enough. So sometimes you have to do deeper, dissection deeper in a deeper part compared to the cranial superficial part, but it's extremely important for your disc to hold. Regarding the implants, a lot of implants available. In general, from the keel type, now they've gone to simple cage kind of implants. So there is not much science left behind placing these anymore. So these will just go inside after you place the trial, and they will just hold there. So you don't need to prepare a keel. In general, the key points are that be mindful of the midline all the time. That's why you need to have a radiolucent table. Also extremely important that you should be able to see that disc level on your lateral X-ray. Otherwise, don't attempt disc replacement that level. Also, use trials to get the maximum appropriate footprint. So there's a tendency to go for a smaller footprint because you have not done adequate decompression. So don't do that, because that is likely to migrate or fail. Also important to place the construct as posteriorly as possible, as I told you, also because you will only be able to get natural movement at that level if you are posterior enough. Avoid this over distraction. Use the interfacial space as a guide, and use AP and lateral fluoros to avoid malposition, and take help check out the movement of the implant. You can do that by lifting shoulders or the head. And this is just one final slide. So this is how the displacement should be, so that you are able to make sure that the movement continues even after a few weeks and months and years of the surgery. Thank you so much.